We're going to go ahead and get started for our next session of Virtual Global Spine. Today is a little bit of a different, based on the topics of our conversation of our last Virtual Global Spine conference, the issue of indications and possible uses of cervical arthroplasty devices was brought out pretty significantly. So it's not something that we really talk about very often. It's relatively, it's not a very new technologies. But they have not really reached broad market appeal for certain reasons that I hope that we can discuss today. And we're going to try to kind of go through this, a lot of information, but I'm really distilled it down to the most important things, kind of all the takeaway points that we need to see for these devices, and ideally discuss it amongst our faculty hosts. So I'm going to start off with a case example, and I'm hoping that people can participate in the chat. Just go ahead and type in your answer for what you would want to do for this particular patient. It's a 36-year-old man with medically refractory neck pain. Primarily, his predominant symptom is neck pain with left upper extremity radiculopathy. And what you can see here is a C6 distribution. Say 3, 4. So let's just say, actually, that's probably a mistake. Let's just say C5-6 distribution radiculopathy on the left side. And he's medically refractory, meaning that he's gotten, let's say, he's on occupational therapy, he's gotten an epidural steroid injection, he's tried gabapentin, the typical stuff, Medrol dose pack, and he comes to you seeking surgical evaluation. So we decided, let's say, to operate on this patient. So I don't think this is going to work, unfortunately, but let's just say these are the options that you have for this patient. So for that soft disc herniation at C5-6, you can do potentially an ACDF with an anterior plate in a gentleman who has neck pain and unilateral radiculopathy. Anterior cervical discectomy infusion with a standalone inner body, meaning no plates, one of those integrated plates where either you have shanks or screws that go inside that disc space. How about a corpectomy and fusion, an arthroplasty, or a posterior keyhole for amyotomy? Maybe one of our hosts, I can't unfortunately see the chat box. I'm wondering if somebody could maybe tell me what the consensus is.
So we should ask Ali what he thinks. Oh, yeah. You can unmute yourself.
I just unmuted you, Ali.
Yeah, we're Dr. Rasouli has full control today, so he can mute it, unmute us at will. Thanks, Jonathan, and that's obviously a great case to start with. A very common scenario, right? We see that in clinic day in and day out, and obviously you mentioned, I mean, obviously it goes without saying, but I just want to make sure that everybody in the session understands that, of course, this patient exhausted medical management, right? You don't want to jump straight to surgery. Exactly. So, but let's just assume that he has failed medical management. He has tried injections, physical therapy, NSAIDs, and it's surgical. So now the $1 million question is always the same, right? Do you go from the front or do you go from the back? And if you go from the front, are you doing an arthroplasty or are you doing an ACDF? I can tell you this, that in younger patients, I do like the arthroplasty option. There are some who believe that even, in the elderly, it's okay too, and they have good results. But I can tell you for younger patients, for a 1 or 2 level degenerative disc disease that's symptomatic, I do like the arthroplasty option. Maybe about 2 or 3 times a year, I'll do a posterior foraminotomy. I know some surgeons that's a little bit more popular. That has a very limited indication in my hands, but that's also a very good, obviously motion sparing, no implants, no, low cost surgery. But for this particular case, I would personally choose a arthroplasty for this patient. And I would always get a flexion extension pre-op to make sure that they don't have any significant listhesis. That may change my mind, and I may do an ACDF. But in the absence of a listhesis, in a young male, I would probably choose an arthroplasty option.
I got you. Yep, I totally agree, Ali. If this patient had significant kyphosis, or let's say he was predominantly myopathic, would that change your plan of attack, or it would be the same thing?
That's a really good question. And obviously, if a patient has a structural rigid kyphosis, I would not advocate for a arthroplasty there. The problem is in some patients like this one, I would assume, because of the pain, they have muscle spasms. They tend to straighten out their spine and not, they will lose that lordosis. And you actually think that this is a structural kyphosis or straightening of the spine, but it's actually muscular spasms from the pain. So I would need to be convinced that there's a structural, malalignment problem in order for me to switch over to an ACDF in a young patient.
Mm-hmm. Do you believe in a temporary, let's say if this was a little bit fresher, do you believe in like a soft collar or traction? Like not like with pins obviously, but like a halter traction, like just a little strap with some weights.
Yeah. So a lot of patients ask me that. I know some physical therapists will utilize that. I have no problem with it. I have no problem with gentle traction in these cases. I don't know if a collar is going to do anything. I'm not a big fan of collars in general.
Yeah.
Or after surgery, certainly not before surgery.
Totally agree. Okay. Yep. Totally agree. So your choice would be cervical disc arthroplasty in this case?
Yes, that would be my choice.
Got it. Any consensus, Wendy? Anybody?
Yeah, everybody. I voted first, and I voted for A, and almost everybody else did too.
A, meaning ACDF.
They were humoring me, so now maybe they would change their minds though. Yeah, people mostly said AC or E.
AC or C as in a cervical corpectomy? Or like
a couple of people said C.
Okay, so
and others said posterior keyhole. People were all over the map on this. You can tell it's controversial, like you said.
It's so interesting how you can have, just look at it. It's very, if you think about it, right, the pathology is relatively straightforward, right? But you throw in a couple of twists here. The patient's younger, right? And they predominantly have neck pain and unilateral radiculopathy without myelopathy. And you can just see the range of choices are just kind of all over the place. So it's very interesting. So just to show you, okay, so this patient actually ended up getting an ACDF, but you have other options too. I talked about standalone inner bodies, right? These are the ones where the integrated, you have the integrated screws. And the reason you don't have a plate here is, number one, it just sometimes can be a little bit technically challenging for multi-level ACDFs to place a plate. And there's also considerations with preventing the plate from overlapping the adjacent disc space, either cranially or caudally, to prevent accelerated degenerative changes. Now, we discussed the possibility of doing an arthroplasty, okay? So cervical disc replacement arthroplasty, CDR, or total disc replacement, TDR, these are all different terminologies for the exact same surgery. This is not a new technology. I kind of want to stress that. This has been around for a very, very long time. And despite that, there has been a relatively slow adoption in particular academic spine, not so much in private spine. And we'll talk a little bit about that for surgeons to use this technology. One of the main criticisms I've heard by one of my mentors at the Cleveland Clinic, this is Dr. Benzel, is that these arthroplasty devices in many ways are a device in search of an indication, which I don't know if I necessarily agree with, but it's something that to keep in mind, that it's a little bit on the controversial side in terms of indications and when to do it. So a little bit about the background. If you're just going to take a step back and look at arthroplasties altogether, arthroplasties currently, if you look at what's considered to be acceptable and what we can do clinically for these patients, there is data that, whether you choose to believe it or not, okay, and we'll talk about that as well too, is that that a one-level arthroplasty is at the very basic, it's non-inferior to ACDF. And there is some data to suggest that two-level arthroplasty may potentially be superior to ACDF, okay? Again, this is mostly industry-sponsored and industry-led studies with small control groups and heterogeneity when it comes to the type of outcomes that we're looking at, okay? So this all things to keep in mind. The approach for arthroplasty is essentially the exact same surgery as you would do for an ACDF. It's just the classic Smith-Robinson technique. And there's really not too many nuances that are different. It's more the lack of end plate preparation. Remember, you're not trying to get a fusion here. You really have to keep things kind of intact, and you have to really pay attention to taking down the PLL posteriorly and not drilling too much, especially in the inferior or posterior half of the vertebral body in the presence of a large disc osteoid. Okay. Now, why disc replacement? So how did this even come about, and why do we even talk about this now? So there's some evidence to suggest that people who get arthroplasties have a decreased risk of adjacent segment disease at the nearby levels. Okay, and this whole technology came about from the orthopedic literature, where there's been relatively good success of hip and knee replacements. I mean, arthroplasties are essentially standard of care in the orthopedic world for joints. You know, if you think of the vertebral segment as being a joint, right? Why is it that it's not really the same there, right? So there's differences. So really the main indications for cervical arthroplasty are neck pain, okay? So these patients predominantly have neck pain as their chief complaint, and radiculopathy, okay? For other indications, in predominantly myelopathy or patients with severe deformity, the indications for arthroplasty are not as well developed. There is some literature that we'll talk about, but it's not as clear-cut or, let's say, strong as for these indications here. These patients need to be essentially perfect when it comes to their spine, except for that 1 or 2 level disc disease. They need to have normal configuration of their spine, meaning normal lordosis, minimal spine disease at other segments, no dynamic instability, as Dr. Baj said before. You don't want to see these patients on flexion extension x-rays having any sort of overt instability, and they really can't be very myopathic. Okay, so really the best patient is a young person who has a single level soft disc herniation. Okay, now again, this can be done with a foraminotomy, right? But there are certain reasons why you can't do. There are more indications for arthroplasty, or there's a wider range of patients that can be treated with arthroplasty than those with posterior foraminotomies. So why did this come about, okay? And why do we care so much? So ACDF is the gold standard. It's a phenomenal surgery. We know it works, okay? I mean, the literature has been around for decades and decades and decades. Here's the thing. If you follow these patients out over time, okay, and I'm not talking about 1 or 2, I'm talking about 10 years, 15 years, 20 years after their surgery, okay? There's a relatively high reoperation rate and what we would deem to be a clinical success rate, meaning there's kind of a reversion back to the mean, okay? And a lot of that is thought because you're fusing the spine and the subaxial cervical spine is mobile, right? That you are creating a redistribution of stresses on the other levels of the spine, and you are accelerating disc degeneration, okay? So while those patients are okay for the first maybe 1 or 2 years, 3 years, 4 years, when we follow them out over 10, 20 years, right, there's a relatively high reoperation rate in these patients, and it's thought to be due to the reliance on a fusion. So in terms of the marketing of arthroplasties, okay, and why I say that with a little bit of stress is that theoretically, the benefit of you doing arthroplasty over ACDF is that it preserves motion at that segment. There's less risk of adjacent segment disease, and that's based on predominantly animal models, okay? There's no plate. Sometimes there's a little bit of what I call a futz factor. Not that that's any new terminology, but that's the term I like to use. With putting on a plate, it can be a little bit challenging sometimes, especially for multi-level ACDFs. And there is some evidence to suggest that for 2-level arthroplasty may be superior to ACDF. But the cons of a cervical disc arthroplasty is that it's a little bit more challenging. There's more carpentry involved, and there's more at stakes, meaning that if you really only have one shot to make sure everything is kind of perfect for the arthroplasty device to go in, and if it's messed up, then you have to revert to a fusion. You're not going to be able to use it. It will almost certainly fail. And there's a lot of controversy regarding the true incidence of adjacent segment disease. So this slide is just testament showing to how long this technology has been around. It's not new, and the many different devices that exist. The main things to keep in mind are that the Mobic has shown superiority in 2-level disc disease. That's a device made by Zimmer Biomet. And I believe recently the ProDisc C has also come out with 2-level superiority. I may be wrong on that, but don't quote me on that. But I know for sure Mobic has. I do not believe the other ones have as well. The only one that's missing here, I think, is the Security by Globus. But as you can see, almost every company has their own cervical arthroplasty option. So the initial studies that came out about cervical arthroplasty were in the late 90s, early 2000s. It was all only done in Europe, really. And I say that with good results in quotations because these were very, it depends what you mean by good. There's a lot, again, heterogeneity in the studies. The authors defined, they weren't using standardized outcome scales, the typical limitations. But it was enough evidence there to show that maybe there's a signal in this data. And that launched many, many more trials that came out, looking at basically proof of concept type studies, just showing that these things work, these patients do well. And there's many, many of these as we went all along throughout the 2000s. And then in 2007, the FDA approved cervical disc arthroplasties for treatment of cervical disc pathology, okay? And then after that, 2007 was kind of the pivotal moment. When that came about, there was an explosion of all these new cervical disc implants on the market. And this was like the neatest, latest, greatest technology. It was just, basically, this was like the hottest thing. And in moving on from basically 2012 to where we're at now, right, there's been more studies that have come out showing superiority in compared to ACDF for specific interbodies. Like this one, I believe was the Brian or Prestige. I don't remember exactly, but as you can see, that this was a technology that was very, very hot, very, very, very popular. It was adopted quickly when it first came about. Okay, so currently, as it stands now, we have about 6 cervical disc replacement systems that are FDA approved for 1 level cervical disc pathology. Mobic C is approved for 1 and 2, and I believe the ProDisc C is now also for 1 and 2 as well too. Okay, now the thing is that if you believe the literature, which is, again, these are predominantly industry-sponsored studies, all right, there was a less of a reoperation rate at about 2 years compared to ACDF, less of a revision rate, and there was a low removal rate, okay? And what's interesting is, if you look at the trends in usage, as I alluded to earlier, before 2007, remember that was a pivotal moment I talked about, okay? From 2004 to 2007, pre-FDA clearance, there was about a little bit less than 2,000 of these surgeries that were performed in the total of the United States, compared to 320,000 ACDF procedures during that exact same amount of time, okay? Now look at between 2008 and 2010, okay? Basically the first 2 to 3 years this device was approved by the FDA. It went from 1,700 to 8,800, okay? While the number of ACDF procedures were relatively stable, 316,000, okay? So it was a huge increase in the amount of arthroplasties that have been done. Now, to date, it's about 13,000 since 2010. There's been a decline, and the decline has been kind of continuing in that direction, okay? And there are some reasons for that, all right? So I don't know if this is a very popular image. It's Scott's parabola, and this almost fits any new device that comes around, and it really makes sense with arthroplasty as well too. So you have an idea that looks promising, right? You have encouraging reports, right? The first kind of studies that came out. Then there's widespread enthusiasm, okay? Everyone's doing it. It becomes a standard treatment. Arthroplasty for everybody, 2 level, 3 level. Let's just keep going with these things. And then as we start seeing the complications come back and things start going wrong, doubts start creeping in, and there's some, this hasn't really happened yet, a widely publicized medical legal case. And then it basically kind of trends down towards finding kind of a happy medium about where we're going to, where this is going to be, okay? So basically, again, if you take a look at the reviews of all the literature of ACDF and all the literature of cervical disc replacements, the reoperation rate, long-term, not short-term, long-term reoperation rates for ACDF are about almost close to 10%. And with age-adjacent segment disease is 11 to 12%, okay? With cervical disc replacement, all right, the reoperation rate, if you choose to believe it, is less with less adjacent segment disease, and these patients tend to return to the prior level of activity faster than those who get 1 or 2 level ACDF, okay? So And this is all pulled from this review. Okay, so a quick question. I just want to see if you guys are awake. Which of the following is a contraindication to cervical disc replacement surgery? 1-level disc herniation, C7 radiculopathy, greater than 2-level degenerative cervical disease, or absence of dynamic instability on flexion extension.
Well, I think, Jonathan, you do have surgeons that can off-label, of course, do 3 levels. Sometimes they do hybrids, and I'm sure we're going to talk about that. But I think you're talking about the official FDA, the FDA indications, correct?
Yes.
Got it. Okay. So I think looks like Wendy, everybody's choosing.
C.
Everybody's choosing the right answer.
C. Good. You guys are awake and paying attention. I haven't bored you to death. All right, good. So what's new? So there are more discs on the market. That's kind of the main things that have been going on. We're getting longer term studies and trials that are coming out now showing the benefit of arthroplasty. And we're starting to have like better data that's out there. It's not just like industry sponsored studies with authors who have conflicts of interest. It's actually much more unbiased. So we have better evidence supporting the use of these devices. Okay, and now there's some nuances with we're learning some of the mistakes to avoid with some of the earlier trials. So this has brought the complication rate a little farther down. So there's some hope and promise here. Okay. So in terms of long-term follow-up, some of the studies have come out recently. So looking at the Bryan disc, at 10 years, there was no significant difference, but there was a trend to lower adjacent segment disease. Okay. At 2 levels, there was with the prestige discs, with 2-level arthroplasty at 10 years, there's a better neck disability index and fewer reops. And with the prestige 1-level at 10 years, there was a slightly better neck disability index, but with patients who with reops. But basically, at around 5 to 10 years, these things kind of reverted back to normal. So there's a lot of data out there. Some of them show there's no difference. Some of them show that there was less adjacent segment disease, but no difference in reoperation rates, so on and so forth. It's kind of all over the place, really. So now the thing is that if you look at the meta-analysis systematic reviews, some of them show decreased adjacent segment disease revisions, right? These are the ones here. I just kind of listed them. I guess when we post this, we can take a look. I don't want to go through this in too much detail. Some of them show no difference. Some of them show improved NDI. All right. So think about that. You have studies that show there's no difference, studies that show that there is a difference, and studies that show that it's slightly better. We don't really know, right? So it's the same problems that we ran into before, just in a different way. But here's the thing. Again, a lot of these studies are industry sponsored, conflicted, and there's some questions of I believe the Freelander Effect, where the patients know they're being studied, and they know that they're part of a large study looking at these outcomes. They tend to report their outcomes a little bit differently when they know that they're being observed in the study. So,
Jonathan, which way did they report when they know they're being observed?
You have to look at it. It's very dependent on the way the questionnaire is worded. It tends to be that the effect tends to be that if you look at it overall with the Freelander effect, is that they tend to report it more positively than negatively because they know they're in the study. That's not. I'm not speaking uniquely to arthroplasty, but just kind of in general. So basically, we have other data, like we have European data, and if you look at some of the other registries, not the United States literature, there's not really that much of a difference. So it's again, it's kind of all over the place, really. German literature says there's no difference in outcome. Doesn't really show there's any difference in outcome with lower costs. So some of the questions that I have, and now that we have much more experience with these devices, is that do these devices restore motion? And what about heterotopic ossification, right? Because that's one of the main problems with these arthroplasty devices, that they can fuse over time and they don't keep the motion. Does it change alignment of your spine? And do 2 levels truly do as well as 1? And can we potentially expand the indications for total disc replacement for patients who are myopathic? And then there's some question about why do a cervical disc arthroplasty when you could do a standalone ACDF? Because that seems to be kind of, if you think about it, there's no plate involved, and they're very similar in terms of the technical nuances. So, there's some people who would favor that versus TDR. So speaking about this, so does the TDR restore motion, okay? If there's no movement of the disc before the disc replacement, right? It does not move very well after the arthroplasty. So if the disc is not really moving before surgery, if you arthroplasty that level, it doesn't really move very well after, okay? And motion is maintained, but at about 10 years after these surgeries are done, it's not really as good as, they lose motion over time is what I'm trying to say, okay? And with 2 levels, okay, we did have the Mobic data, which was at 5 years. I believe they're coming out with a 10-year data coming out pretty soon. And that showed that it was a potentially superior to fusion in neck disability index, but there was no difference at a single level. So again, whether you want to believe this data is, how much you want to rest your hat on this data is very kind of up to the surgeon itself. Now with patients who are myopathic, because I wonder about these patients a lot. These are patients who, you see that they have a soft disc, but they're predominantly myopathic. Could you potentially do an arthroplasty on them, right? So there are some early results showing that these patients are a little bit slower to recover, but if you follow them out over time, then there's no difference from those who undergo ACDF. But there is data for the Bryan discs that show that at the index level where you operated on, there is a rate of recurrent stenosis at that level. So if you think of the myelopathy being predominantly caused by an extradural pathology, let's say a herniated disc, right? You take that disc out, you relieve that extradural pathology. There is some data to show that arthroplasty then leads to index restenosis in the long term, okay? So now here's the thing. To date, there really are no good studies comparing the arthroplasties between each other. So we don't really know if one is better than the other, okay? And there is a predominant amount of data, not necessarily definitive, but there is a signal there showing that that in select patients, a TDR may truly reduce the risk of adjacent level surgery. It's not a guaranteed thing though, okay? This is really, really kind of, in many ways, kind of flip a coin whether or not this is actually going to happen. But there is data to show that there may truly be a decreased incidence of adjacent segment disease for patients who undergo arthroplasty compared to ACDF. And in those who are unselected, meaning that they are not like kind of the perfect patient, there may be no difference, okay? Now, this is one of my favorite reviews for arthroplasty, and I suggest that if you have time to look over this, I would suggest that you look at this, because this is one of my favorite. The conclusions of these authors is just, I thought, phenomenal. And I'll literally read this verbatim. This was done at Cleveland Clinic. So when you looked at essentially all the things that arthroplasties purport as being better than ACDF, okay? So adjacent segment disease, motion preservation, faster return to work, okay? If you looked at the author list and you looked at authors who had a potential conflict of interest, okay? Conflicts of interest were more likely to be present in studies published after 2008, and those with a conflict of interest reported greater adjacent segment disease rates for ACDF than cervical disc arthroplasty. In addition, heterotopic ossification rates were much lower in studies with conflict of interest versus those without conflict of interest. Thus, conflict of interest did not affect quality of life outcomes, right? But were associated with lower complication rates. Depends on how you want to interpret that, okay? So it's important. All right, so going back, same patient, same pathology. This is the one I showed you before. I want to know what people would do. So knowing what you know now about arthroplasty and ACDF, what would you do for this patient? Has anything changed?
Yeah, it'd be interesting to see what folks think and if anybody really changes their mind. I'll tell you one thing. I'm going to stick to my choice, which was a one-level arthroplasty. And for the record, I'm not conflicted, and I don't have any interest in any device. Let me put it that way. But I think arthroplasty is a good option here. But while folks answer, Wendy still chose A. She still went with ACDF.
Hey, so did Coy. I'm voting with Coy.
Oh, Coy did the ACDF too?
Coy needs some support since he's not talking here. So.
Jonathan, let's find out from Coy why he chose ACDF over arthroplasty. Do you mind? Let's get him involved.
I do not mind. I'm unmuting him now.
All right, Coy, why do you think why do you think ACDF is better than arthroplasty?
Hey, can I chime in a little later? I got a fussy baby.
Okay.
Yeah, baby.
I guess your excuse, Coy. That's okay.
Jonathan, let me ask you this, and I'm sorry, I apologize if this is in your slides to follow, but it's like MIS surgery, right? A lot of us, the ones that do it talk about it all the time, but the reality is, really less than 10% of spine surgeons are doing MIS, for better or for worse. I'm not saying that's right or wrong. Same thing with the arthroplasty. I think, the people who do it talk about it a lot. They like it. But based on what you've shown, and I think you would agree that the literature, it may not support that arthroplasty is better, but it's certainly not inferior by any stretch of the imagination. Why do you think it just hasn't been as widely adopted as you would otherwise think? If it's equitable, if there's equipoise, if one can do an ACDF or an arthroplasty, is it just because most we're trained on ACDF and it's easier and more forgiving? But I just feel like it's like MIS. It's just really not going to be widely adoptable. What are your thoughts on that?
Yeah, I totally agree. I think if you just look at basically, imagine your last 50 patients, right? How many of those patients were truly the best, excellent, like the perfect arthroplastic candidate? It's relatively rare, right? You basically need someone who has just really focal, isolated disc pathology. It's basically just a young, like I said before, a younger patient without too much spondylosis, no spondylolistheses, no kyphosis, is not myopathic, right? So those patients are pretty rare for the most part. I mean, if you look at the incidence of degenerative disc disease in the cervical spine, it increases pretty dramatically as we age. And and it's not just isolated to one or two levels. Often these patients have multi-level pathology. So for the vast majority of our practices, we do ACDF, and that's what we predominantly do here at Cleveland Clinic. So when these patients come around, by the time they come around and you get that perfect arthroplasty candidate, you're just so used to ACDF. And it's predictable results. It's been around for a long time. If those patients have kind of subtle myopathic symptoms, which they sometimes do, you know that the results are going to be, you know what you're going to get with ACDF. It's a little bit unclear with arthroplasties. And also with the nuances of the surgery itself, there's more at stake with an arthroplasty. I mean, certainly when you get kind of slick with the procedure, there's probably no different. I don't think there's anything comparing differences in operative time. But as you get slick with that procedure, then obviously the differences in your operative time are going to come down. That being said, I know several surgeons in private spine practice who basically are, the vast majority of their cases, they're much more liberal with their arthroplasty indications. And if you look at the data, there's some recent, there's an update to that trends in usage paper that I cited before. It just came out about a year ago. If you look at who are the predominant users of arthroplasties now, it's very interesting. The vast majority are private spine surgeons in the South, meaning Texas, Oklahoma, that region they consume something like, and if you include Florida and basically all the South, private spine surgeons are something like 60% of the arthroplasty users. Whereas in other regions, it's almost like not even used at all. It's unbelievable. Like Northeast, it's like essentially nothing. It's like California, West Coast is like maybe number 3. But it's very, very interesting to see how regional it is in terms of arthroplasty usage.
Got it. Thanks, Jonathan. I think Dr. Tan here is back with us. Do you want to unmute him? First of all, Coy, is the baby safe? Did you put the baby in a safe spot?
Yeah, the baby is in the closet. Okay, Jonathan, first, This is probably one of the best cervical arthroplasty lectures I've ever heard.
Nice.
You're killing it. Now, let me tell you why I would vote for ACDF. Can anyone tell me what year the first cervical arthroplasty was developed?
It's like 98, 99, right? Like,
1966.
oh, wow. Okay.
It's been around for a while. And if you look at the best arthroplasty devices in use, to your point, probably hips and shoulders, what will every orthopedic surgeon counsel their patient as to how long that device will last? 20 years probably, sometimes a little more, sometimes a little less. And so, we're pretty jazzed about, 10-year data. I think it's going to be really interesting to see how things shake out over the next 10, 15 years for sure. Whereas with ACDF, you have something that's really tried and true. And to your point, that paper out of your institution, the Cleveland Clinic, I think it's one of the best comparing ACDF and arthroplasty, because basically when you take out all influenced studies, whether it's industry sponsored or where authors have a conflict, there is no difference in terms of basement segment disease and whatnot. So I do arthroplasty, but to your point, it's truly in like a perfect patient. And I actually once counted, I do like for every one arthroplasty, I do like 14 or 15 ACDFs.
Yeah.
So, so that's why I voted the way I did.
Awesome. Do you, if you had to say, kind of ballpark, Ali and Koi, the amount of arthroplasties you've done, let's say in the past, like, I don't know, like 3 years, or let's say 5 years. Maybe that's too much. I don't know. Let's say the past 2 years. How many arthroplasties you've done?
How many arthroplasties we've done in our practice?
Yeah, let's say in the past 2 years, just ballpark, roughly.
Yeah, I probably do about a half a dozen a year, about 6, maybe 6 to 8 per year. And I'm a big fan of it, by the way. I'm a big proponent of it. I can tell you that I have patients that come and ask me for it, depending on what what the demographics are or what kind of market you live in. I can tell you that, and I'll be interested to see what some of our colleagues in the chat box say. I see here Dr. Selby from Australia, Dr. Baisa from Saudi. But here, as you guys know, sometimes patients do their due diligence, do their homework, and come to you asking for a specific procedure, right? Now, if it's not indicated or it's wrong, you absolutely should not oblige. But if, we do have patients who come in and say, you know what, I don't want a fusion. I just want the laminectomy. I know there's a risk, I know there's a risk, et cetera, but I just want the lamia. I have other patients say, I want the arthroplasty. And I actually, just because I do offer it, I've actually have gotten some patients from other surgeons who don't do arthroplasties. Again, not a big number, but that also weighs in a little bit is what patients' expectations and patients' wishes are. But you definitely have to be honest with them, intellectually honest about the risks, the long-term benefits. And what I tell them, going back to Koi's point about what's going to happen after 10 years, I don't know, but in my opinion, worst case scenario, it turns into an ACDF, turns into a fusion, right? I don't know the answer to that, but I think it's a good tool to have in your toolbox. Let me put it that way.
Can I ask a question before we get too far from what you just said, Ali? Because you just hit on something that I've been wondering and I wanted to ask when there was a chance. So there are probably a few non-surgeons here and people who have not seen patients and talked to them about this. When you counsel patients, this seems very complicated to me, all the data and all this stuff. I don't know how any patient could understand this. I'm thinking if I came to you, well, I wouldn't know what to ask, or I just leave your opinion. So do you kind of know, I guess this is to Rasouli, do you know ahead of time what you want to do and you kind of guide the discussion that way? Or do you provide them with a lot of evidence? Or how do you approach your patients with these issues if it's so controversial and the answers are unclear?
Yeah. So that's a great question. So basically, it's one of the most complicated parts of our job if you think about it, right? When you have a patient in clinic and they have a pathology, right? So going back to that example I showed, right? It's like a young guy with a herniated disc in his cervical spine with neck pain and radiculopathy, right? Look at how many different answer choices I gave and look at how many different choices people gave, okay? And if I asked audience member to justify the reason for why they picked that, I guarantee you every single one of them would have a legitimate point as to why they wanted to pick that choice, right? The bottom line is that your decision the decision for surgery that you advise a patient to, whether or not remember, it's their decision whether or not they want to go with you as a surgeon when the case is elective, is based on your skill set, based on your training, based on your personal beliefs. In some cases, it's guided by your conflicts of interest, which may be conscious or unconscious. It may be driven by your biases. There's a lot of psychology that goes along in this decision making. But when you feel that you've made a decision for this patient, say, okay, I think I want to do an ACDF on this patient, right? You're going to essentially sell them on that procedure and explain to them why you think that's the best choice. If they subsequently ask and say, well, how about arthroplasty, right? It is incumbent for you as someone with spine training to advise them, or rather counsel them on what that procedure entails and why you don't think it's a good option, okay? The one thing you don't want to do is to provide like a menu for a patient like this, like literally it's like, here you go, this is what I can do for you. Which one do you want, right? That never works, okay? So when we would do ACDF versus arthroplasty for that patient I just showed before, it's really up in the air. It's really what there's nothing to say that one is better than the other really, because you can justify either one of those things. But it's really up to you as a surgeon to kind of pick what you think is best based on your skill sets, based on your outcomes, and just go with that and advise the patient on why you decide that. Now, it's up to the patient whether or not they want to take your advice, but that's kind of incumbent on you as a surgeon.
Yeah, great answer. Great question too. Great question and great answer. And I can tell you that, Wendy, I think it's an evolving process. It's an evolving relationship. But it is very, and you know, some of you guys that know me quite well, you know, I'm very, very big on kind of patient-centered care and patient satisfaction, if you will. I think the key is, in my opinion, is there are some patients who come to you knowing what they want. And there's some patients that come to you and just trust you 100%, do whatever you think is right for me, doctor. And I think the art in what a lot of us do is knowing which patient is which and making sure they're happy with the result. And it's really an art. It's like I hate to be romantic about it, but it's like a dance. It's, you know, you kind of feel for the patient, you kind of understand what they want, and very quickly you can guide that discussion towards what they're comfortable with, as long as it's medically indicated. I mean, I have patients, say, with severe scoliosis who want a 3-level laminectomy. I say, I'm not going to do that without stabilization. But if it's, say, let's say grade 1 spondy, an L4-5 grade 1 spondy, I think they would benefit from instrumented fusion. But they say, you know, and this just happened today, literally today. And they said, you know what, I understand the risks. They're very well informed, but they want the less invasive, you know, tubular decompression. I'm going to go ahead with that. So I think you really have to listen to your patient and engage them in the discussion. That's important, I think, for any topic. Coy, what do you think? We muted Coy again. Coy, what are your thoughts on that? How much liberty do you give to your patients in terms of decision making when it comes to procedures like this?
No, I think my approach is very similar to yours. Generally for arthroplasty, you know, I will talk to them about, if I consider them arthroplasty candidate, I will talk to them about arthroplasty versus ACDF. And generally, you know, they like the thought of the concept of, you know, motion preservation and whatnot. But, I think my approach is very similar to yours.
Are there any questions that people have? Anything in the chat box, Wendy or Ali?
Dr. Sel, from the chat box here, Mike Selby made a great point, you know, and that's a great point to counsel the patients, going back to Wendy's question, is if a revision is necessary after an arthroplasty, sometimes the only way to revise it is with an extensive corpectomy, and sometimes, you know, multi-level corpectomy, and then it becomes a big operation. So counseling patients on revision cases and you know, what happens should you need to revise a case is actually very important and sometimes overlooked by us, right? Because we don't think about that.
That's very true. Yes, this is very, very true. And you know, another thing, Ali, you asked me why people have not adopted the interbody is one thing. I forgot to add, a lot of these devices have a keel in the center of it that is exceedingly difficult and a giant pain to make sure everything's kind of perfect with all your drilling in order to put that in there. It takes some time to get good at that. The Mobi C does not have that, and that's probably why right now it's the #1 arthroplasty system. But it is a gigantic PIA, if you know what I mean. So it's not something that people like to deal with. You're done with the case, you got everything done, you kind of just want to get out of there, but you have another thing to worry about. And if there's any mistake in that whole process, the whole thing is done. So anyway, all right. So it doesn't sound like any questions. We'll move on. I don't have too much time, so I want to just kind of get through this a little bit quickly. Does that sound good?
Yeah, sure.
All right. Okay. So next case. Much more controversial indications, okay? So MRI lumbar spine, I'll give you the background here. It's a 35-year-old woman who comes in, history of axial low back pain, has tried multitude of different medications, has had some temporary relief with them. Nothing's really getting much better. She's crying in your office. I can't walk. I can't live my life. I can't work anymore. I don't know what to do. Okay. And she has her MRI and CT. I didn't want to go through all the axials and everything. Let's just say you have like just basically central indentation of the thecal sac or some neuroforaminal stenosis, the typical stuff, mild to moderate neuroforaminal stenosis. Same thing at L5S1. She's tried epidural steroids, didn't really help. What do we do for this patient? Would anyone? So I don't want to, in the interest of time, would anybody get a discogram on this patient?
The discogram question, is that what you just asked?
Yeah, would anyone get a discogram on this patient?
What's a discogram? No, I'm just completely kidding. Actually, this would be great to hear what Wendy thinks about it, and see how many actually she gets referrals for those, because there's no question that everyone is doing a lot less of them. Wendy, do you get a lot of referrals for them still? What indications are you seing for those?
Yeah, that's really interesting, because my training at Barrow was 5 years ago? Yeah, whatever. I had one or maybe two, because at that time nobody was doing them. That's when everybody was saying it causes or it accelerates degeneration. It's in the normal discs. So that's what I learned. Then like 2 years ago, we started getting a bunch of requests at USC for them, and nobody knows. I mean, some of the older guys knew how to do them. I've done one or two, but we're like, why do they want to do them now? Because we were told they're so bad. But I think, as always, things go up and down, and kind of it's back up on the upswing. People want them again. I have gotten several requests. I've never done any more though, or maybe I've done one. Somebody in the chat, Mike Selby, said analgesic discography. That's the one or two that I've done were that. They weren't like the 3 levels. It was 1 level with anesthetic, which is not the way I guess they used to be done. Yeah. So yeah, it's very interesting question. I don't know if that tide is turning on those. But I have a friend who does tons of them. He does many a month in Minneapolis, very famous private practice neuroradiologist, Blake Johnson. So he's like the king of discograms. So I guess maybe it's also regional. I don't know.
That's really interesting. I just as an analogy, Jonathan, Wendy, and others, I think like a discogram is like an EMG. When you don't want to operate on a patient, you order it, right? Because you want to see a negative. But yeah, this is a tough case. So what are your thoughts on this, Jonathan? What do you end up doing?
So this was not my patient, but I was prefaced by saying that. But so what if I told you this patient had a positive concordant discogram at L4-5 and L5-S1? So anyway, the bottom line is this patient ended up getting a 2-level lumbar arthroplasty. Okay, not at Cleveland Clinic, but this is a very controversial pathology. This falls within the spectrum of so I didn't show you the X-rays, but this patient didn't have any overt, let's say, spondylolisthesis on X-ray. The alignment was good. This falls within the realm of black disc disease and discogenic back pain. And whether you believe that that's truly a indication for surgery, and whether you believe that entity even exists, okay? Now, people who believe in black disc disease and believe in discogenic pain will say that you have a patient like this, right, has horrible pain, has received some sort of alleviation of the pain through the typical modalities, right? And every single disc is good, except for this one and this one, right? So how can you say that black disc disease or discogenic pain doesn't exist, right? And it's not, and then they have a positive discogram, right? How can you say that it's not the disc that's causing their pain, right? And and for all people to say that, you have many people who also will argue and say that this is purely a radiographic finding. You have people who have these kind of findings on MRI that are perfectly fine, walking around, no pain whatsoever. There's a lot of procedural reason why discogram is not done. Not only this accelerates degenerative changes, but there's also certain things with the technical aspect of the procedure, like if you do it a certain way, you can elicit pain, but if you don't, you know, it's like, it's kind of in the operator's hands whether or not how believable the results are. So it's it really is really kind of a difficult pathology. So anyway.
But Jonathan, there is just one more option. Sorry to interrupt you. You know,
my option too. Are you going to say my option?
Oh no, not surgical option. I meant there's one more, you know, you said, you know, how can you believe or not believe in discogenic pain, or is this just a radiographic finding? I think there's one more option, which is, to be honest with you, what I tell patients is your pain is probably coming from this bad disc. I just don't have a good surgical cure for it. Do you know what I mean? So you can still agree and you know, believe that patients will have pain from that terrible looking disc. I just don't know if, you know, of course, case by case, sometimes I just don't know if there's a good surgical option for it. So I just want to throw that in there because, you know, I certainly believe that patient's pain could be coming from that.
I want to throw my option in too before he goes to his answer. And that's as a segue to maybe a future virtual spine we're going to have. Because you all, I think Coy too, has heard of basivertebral nerve ablation. And that's a relatively new procedure. I don't know if surgeons do it, radiologists do it. And it's been in the trials now for a little bit. So we go in there, and for people with axial discogenic back pain, and you burn that basivertebral nerve, and that's been shown to relieve their pain without surgery. So our current president of the ASSR, Dan Nguyen, is one of the people that was on those trials, and he said he would come talk to us a little bit about that.
That's definitely an option. I would say, I would just caution you to that for the same reasons why we tend not to, you know, we need to see bigger trials. You know, there's always the thing of conflict of interest and small cohorts, and, you know, you need to really we need to see bigger studies before it's going to have widespread acceptance. However, that being said, the study, I read the study they're talking about.
He was ready for my question.
It's very well designed, and it's interesting. It's very interesting. I like the theory, the pathophys behind it, because it makes a lot of sense if you think about it. But we'll have to see. The jury is still out on that. So this is the main pivotal trial that was published looking at lumbar arthroplasties, okay? And I want to point something out here. Not so much the results, because obviously the authors found the results were positive, right? But I want to show you what they deemed to be a positive result, okay? So again, this is testament to, and this study in particular is testament, and I use this as an example of how you really need to look behind the you know, I'll admit, I sometimes when I'm doing things, I look at the title here on PubMed, and then my eyes just go, boom, conclusions, right? Oh, Proziscal has been found to be safe, efficacious, and probably solution in patients, da, 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 da. Okay, great. Lumbar arthroplasty is the greatest, right? However, look at the results, okay? Without me actually pulling out the paper and going through this nitty gritty, okay? Look at what was deemed as being a positive result, all right? So there were 0 major complications, right? 91.8% of investigational, 84.5% of control patient reported improvement in Oswestry low back pain disability questionnaire, and all these other things, okay? The improvement criteria in this study, okay, was a greater than 15% improvement in your ODI, okay, from pre-op. So if your ODI was slightly increased from pre-op, you were deemed to have an improvement in your thing. So if you look at that, that's literally, what is that, a couple of points here and there, and that could just be an effect of the patient coming to clinic. There's so many things that can factor into that, but that's what was deemed as being a positive result, okay? And there was a high reliance on the visual analog scale, okay? The VAS, which is probably the most rudimentary of all the patient-reported outcome instruments, right? Because now you have much better ones. You have PROMIS scores. There's so many better ones out there, but these are like the most basic of the basic, okay? So those are the things that they've found and deemed this as being a positive result, okay? Just keep that in mind. Now, if you look at the indications for lumbar disc arthroplasty, okay? So this is a very, very, very nice review written by Dr. McAfee. So it's indicated for 1 or 2 level discogenic mechanical back pain, okay? Discogenic mechanical back pain. I have always been taught that those are 2 separate entities. There's discogenic back pain and there's mechanical back pain, right?
Yeah, that's
And we know, right? And I didn't know that they coexisted. That's new to me. And another thing is that we know that patients with mechanical back pain, so those who have a deep agonizing pain that's exacerbated with loading and movement and alleviated with rest, those patients tend to respond well to lumbar fusions, right? As compared to patients with discogenic pain, which in itself is a controversial diagnosis, right? It's a very, very controversial diagnosis. Those patients apparently can respond to arthroplasty. It's very similar if you think about it in the cervical arthroplasty literature that I talked about before. It's kind of, it's something similar along that same vein. And then again, you have patients with chronic back pain, and that tends to be more a syndrome of poor sleep, depressed mood, basically no response to any sort of treatment modality. It's a different entity altogether. And unfortunately, if you look at the literature, a very significant portion of our lumbar fusion patients tend to be chronic back pain patients. And those are patients who will not do well with any sort of surgery, for the most part, will not do well with any sort of surgery that you'll do for them. So it's interesting stuff to note, okay? So, So I had more slides here. I just want to kind of skip through. I just want to touch base in the last 2 minutes on one more thing I just want to talk about, because this is a relatively new technology. And I just want to touch on it because I don't know if you guys have seen it. So 68-year-old lady, chronic low back pain, neurogenic claudication, has a grade 1 spondy at L4-5. She has a past medical history of congenital hypercoagulability. Not that it really matters here. What would everybody do? She's got an NSAIDs, PT, the typical stuff. She got a TSI at a L4-5, 100% pain relief, came back after, let's say, a month or so. She's independent with her ADLs and IADLs. How many of you people are going to, A, repeat those modalities, 2, decompression only, no fusion, or 3, LAMI fusion, and it's up to you which one you want to do. Either, say ALEF, or you want to do TLEF, or you want to do decompression posterior lateral instrumentation only with no interbody. Who would do what here? Out of curiosity. I'm just curious how many people would just fuse this patient versus decompress only.
Yeah, Jonathan, I think a lot, several of the folks who've answered already, Coy, myself included, and a few other surgeons probably would go for a decompression fusion, mostly MIS TLIF. There's, yes. You can also do open, of course, but I think there's a good case for a MIS TLIF.
For sure. In particular, I didn't mention this before, if let's say she has mechanical back pain as well, this is like an open and shut case. This patient, I'd say in greater than 90% of people will get a decompression infusion, okay? So now, what we did was something called a TOPS, so L4-5 TOPS. So what TOPS stands for is a total posterior spinal arthroplasty system. It's indicated for single level, and now they're gonna come out with 2 level pretty soon for degenerative lumbar spondylolisthesis. There are certain contraindications. There are patients who are significantly osteoporotic, have a large disc herniation. They have discogenic back pain, as I mentioned before, prior surgeries, ischemic spondy, so on and so forth. They're not good candidates for this procedure. So it's not that many patients who are a good candidate, but in a patient who has isolated slip with not a significant disc herniation and they don't have a lot of other things going on, you can successfully do a decompression. Basically, what's thought of is you're decompressing and you're preserving the motion of that segment. You're not going to have an increase in the slip. So the main study that was done was published in 2015. It was a 7-year follow-up study. They looked at about 29 patients, so there's a small cohort there. Mean age was about 61. They looked at 3, 4, and 4, 5. They saw a drop in the VAS. Remember my thoughts on the VAS, the most rudimentary of rudimentary patient-reported outcome instruments. It went from 56 to 19, 83 to 8, okay? and their ODI went from 49 to 8. So that is pretty good. Okay. And there was no slip progression. There was one device malfunction, and there was one who developed a herniated disc at L3-4. Now, what's interesting here is what they found was in patients who got MRIs of their lumbar spine about 2 to 7 years post-op, okay, they found that there were no cases of stenosis spondylolisthesis. And in 4 patients, they found some evidence of fluid in the adjacent segments in the synovial, in the facet joints. But apparently it did not really mean anything, okay? That's interesting, right? It does show that there are some surrogate signs of instability that were developed, however, those patients were asymptomatic. So it'll be interesting to see how the longer term results pan out, and in authors who obviously don't have conflicts of interest. So this is for this patient, this was the initial study, this was the initial surgery that was done. This is a follow-up scan 1 year later, and this is a follow-up scan 2 years later. As you can see, there's really no progression of the slip. There's no evidence of adjacent segment instability or stenosis above or below, and she was doing very, very well. And this is the MRI that we got in 2017, and this is the MRI in 2019. Pretty much shows, and I didn't show you the facets, but there was no fluid in the facets above or below. So it not bad, and it's certainly a potential option for patients. And again, there's no study right now comparing fusion to TOPS, but it's another type of arthroplasty system in addition to the traditional lumbar arthroplasty that we know about, which I did not talk enough about today, which hopefully we can talk about at another time. So we're already over time, and I apologize. All right. So any questions, any controversies, anything anyone wants to pick up?
That was terrific, Jonathan. Thank you for that. That was obviously there's always a lot of controversy in those topics, but I think we still have to discuss them. They're around. The technology is always exciting. You know, a lot of people ask me about certain things that I do or not do, and I say, you know what, they may not work, or I may be wrong, but we'd like to be the ones that prove it. It's part of the scientific endeavor. It's part of academics and what we do. Dr. Goodwin asked, just so we know, are you a consultant for TOPS? Yes or no?
No, I have no financial disclosures to
okay. No, that's an important question.
I don't even know the people.
That's a very important question. We want to make sure we disclose these things. But that was a great talk. I'll close things up since I'm going to take next Thursday's session, I believe. So for everyone, next Thursday, your faculty hosts here will be helping me, and I will be presenting on complex thoracoabdominal approaches, thoracoabdominal, thoracolumbar approaches, trauma, deformity, tumor, just some more anatomic and technical based discussion using cases, of course. I think especially the trainees, students, residents, junior surgeons will find it very helpful. I have several videos and photographs, both cadaveric and surgical, just to kind of discuss some good old traditional anatomy and technical points of complex approaches. Of course, our flyers will be out in the next few days. And I hope you can join us next Thursday. If nobody else has anything to say, Wendy, Coy, or Jonathan, we'll see everybody next Thursday. Great. Have a great night, everyone. See you next week.
Take care, everybody.
Take care. Thanks, Jonathan.